Hello everyone, I am Dr. Kunal Mahajan from Himachal Heart Institute Mandi, and today we will be presenting a very complex case in front of all of you. Here's my team, here's Abhishek. So we will be doing a case in it's a left main bifurcation case with a diagonal bifurcation as well. And patient is 75 years old male. Please show the slide. He had come to us on 26th of August, around 10 days back, with ST elevation inferior wall MI. At that time, he was having severe chest pain, ongoing angina, and he was taken off a primary PCI. The window period was around 9 hours, so he was taken off a primary PCI, and on angiography, there was left main double vessel disease, and RC was totally occluded. Patient was in severe chest pain at that moment. I thought we will do the left main later on. We'll see what needs to be done for that. But at the time, RCA had to be opened, so we did PTCA plus stenting to RCA with a drug-eluting stent, which was 3.5 into 48. And since then, he's on our follow-up for last 10 days, and he's doing fine. But we wanted to stage this PTCA to left main, and today we are taking him up for that. His EF is around 40% EF is there with hypokinesia of inferior wall with posterior wall. RCA was a big vessel. And just show me the last angiogram on just move the PPT further. Yes. So this was the angiogram which was obtained last time when he presented. You can see in the mid segment RCA was totally occluded, and the on your right hand side you can see that this was the post angioplasty result. There was a plaque in proximal RC which we did not do anything about, but we opened up the RC, did thrombosuction, and then deployed the stent, and it was a very good result. You can obviously see. And just show the next slide. And you can see that the left main was critically diseased. On the right hand, in the apicaudal view, it is clearly appreciable. It is of the catheter size, and very tight disease was there. Our catheter was not getting engaged properly also. And on the ileocranial view also, you can see the LM, ostium. In fact, whole of the LM is diffusely diseased. It's very tight disease. And distally also, LAD is disease and a diagonal bifurcation. I think we forgot to include the apicranial view, which another shot which we took. And I will just show you. We have already done the angiogram this time, and just moving on to the present slides, just show the today's slides. We have already wired. The main challenge was just a minute, two slides back. Yes, the main challenge was to hook this. So while hooking it, we just straightened the tip with another wire and kept our run through wire ready. And immediately, as soon as we hooked, the pressure went down because the ostium is diseased, and we passed our run through wire immediately across the LM. Next view. Yeah, this is how we did. We had difficulty in hooking it, and once we hooked it, we immediately passed the wire. Next view. And then we initially entered into the diagonal. Next view. Then with the second wire, now next view, we entered the LAD. Next. So in osteal lesion, this is actually a big problem, because once you can't wait for too much of time keeping the guiding there only. And now these were the views taken. This is the caudal view. You can see that LM ostium is very tightly diseased. Circumflex is okay. There is no significant. It's a non-dominant vessel, and LAD is diseased, in which will be more apparent in the next view. But here you can see the last view. There is a diagonal is diseased here. You can appreciate. And next view. Next view. This is the cranial view. Now here come anatomy is very well defined. You can see here the ostium looks okay, but it is disease as in the other view. But you can see LAD diagonal bifurcation is also there. Although the diagonal is average sized, but I think we need to tackle this also. Initially I had not planned it, but today when we did this angiogram, I think this is a significantly good size vessel, almost 2.5 mm minimum size, and it is critically diseased. So something needs to be done. I think we should do a dedicated bifurcation for this LAD diagonal, and then cross over against from LM to LAD. The main challenge is, I think this lesion is around 40-45 mm. I don't think it will be covered in a single 38 mm stent. And secondly, when you have to do a distal bifurcation as well, stenting from the ostium is not a good idea, because you have to recross multiple times, and probably your wire can go beneath the LM struts. So we decided that we'll tackle the LAD diagonal bifurcation first. We'll place our stent in a zone so that even if we overlap two stents, LM to LAD stent and LAD to distal LAD, they are not across a significant branch. So that is how we plan to do this case. If there are any other ideas, they are welcome. But this is our main. We will do a crush for probably a DK crush, or I think we'll just see mini crush or DK crush for the LAD diagonal bifurcation. And then once we optimize that, we will put a stent across LM to LAD. So this is our plan. We are not going to do anything regarding Circ. Angle is very good. We have already seen in the caudal view. Circ, I don't think anything will happen to that. So this is the plan, and now we are moving forward. So initially we have next view. We have wired both. Next view. Yes, we have wired both LED and diagonal, and now we are going to pre-dilate both the lesions, and then we see how we take this case forward. Give me 2.5 balloon for diagonal. Inflate. 16, 18, 20 down. Inflate. 20 down. Fluoro save down. Keep saving the fluoros. Flow. 18, 20 down. So I think this this looks a good result after balloon dilatation. Sure. I think the diagonal stent is at it's appropriately positioned, and I think we should take a scene. Metronic, yes, this is the Metronic onyx stent. Just it's okay. Result look good. Take. So we're going to take. I'm just dilating the whole thing again. Dilate. The ostium should be fully dilated. That is one of the prerequisites of any crush. 14. Down, down. So once we have dilated that, I'm just removing the uh, removed the stent balloon. Now we are going to crush with a 3 mm. I'm just removing the wire as well. We'll keep it parked in some other vessel. I think is it entered circ. I think you can appreciate that it is very nicely crushed. I think it will be just apparent. Yes, you can very well see that. So now taking out everything, we are just dilate it also. Yes, 10, 12, down, down. Can see the disease has started here only. It's more of fibrolipidic plaque here. And now it is 3.5 at least, and near the diagonal region. This is the where we have stented. I think you can see the crushed portion of stent, and the vessel is 3.5 here. The visibility of onyx is actually excellent when you are doing cases like these bifurcation. So this visibility actually helps a lot, which we actually underscore. Yes, inflate again. You just slightly pulled it, and yes, 8, 9, 10, 11, 12. Right. Fluorosave down. So it's very, you can see the stent is very well expanded. So dilate. 10, 12, 13, 14, 15, 16. Right, down. So we have done the proximal optimization with a 3.75 into 8 O balloon, and now we are sure that our wire will not pass beneath the stent struts. So now we are going to recross. That is actually the rate limiting step now. If we can do it early, I think the case will be finished very early. But if we can't, it will take some time. So the wire which I've parked in, that is why I did not remove it, because I knew I will need it again. So the wire which I parked in circumflex, now this is the same wire. Yes. So that is what, and I think we were very fortunate that this did not take much time. Yes, now it is fine because the way it has entered, and you can see the movement display. So finally, all is well that ends well. Now you can see the balloon movement is smooth. Previously, we had entered through, probably the wire went into the strut, across the struts, into the subintimus, beneath the struts of diagonal stent. So that was causing all the problem. So fortunately, we understood it in time and removed that, because otherwise it would have been catastrophic if that stent had uh, deformed. So dilate now. 10, 12. Now. Fluorosave. No. Inflate. Take a bigger balloon. 2.5 वाला निकालो. 2.5. down. So now we will inflate sequentially. First you will inflate at 12, then you will inflate at 12, and both simultaneously down, right? So this will be sequential inflation and simultaneous deflation. So position the balloon markers. So dilate 12. Now you do. Both down. Down. Right. Done. So we've done an appropriate kissing. So just take a stand boost. So this is the picture now we are having. So it's a good result across the ALD diagonal bifurcation. Inflate. 16, 18, 20. Down. I think time has come. Inflate. 18. Down. Inflate. 16, 18. Down. I think it is fairly well expanded now. I think this looks okay. Huh? And make it AP. Plain AP. Sure. So I think got a good result. We have covered till the ostium, and now just just make it normal. Do it cranial. Push the table down slightly. Yes, make it cranial. So just pull the chin back, inflate. 10, 12. Yes. Down. Inflate. Just a minute. Inflate. 10, 12, 13, 14. Down. I think we have got a fairly decent result. We've got a good result here. I think nothing to be done for. So because L6 is flowing well, it's a non-dominant vessel. There is no pinching at the ostium. I'm not going to do anything about it. Just dilating the left main with a 5O balloon and nothing else. We'll take IVS and we'll move out. So this is the IVS run, final IVS run. Just start. So we're starting from distal, which is, so this is the distal lady, which is looks fine. Here it is slightly, I think we need to dilate a bit more. So just coming proximally, it looks fine here. And we are approaching the POC, and you can see the very good figure of 8 and a very good result proximal to the bifurcation. Again, we are approaching, this is a acceptable result. I think this case made us learn a lot of things. There were some things which we could have done better, and majority of the things otherwise have went in our favor, and we have used the right approaches, tried to use the right techniques, and fortunately, this was not at the beginning. We did not expect even that much of an angiographic result, but now we have got a very good result. Start live. I think this is fairly acceptable. Yes, inflate. 10, 12, 13, 14, 15, 16, 17, 18, 19. Yes. Down. Still not. But I think this is the best which we can do. Can't inflate more than this. Inflate. 14, 15, 16, 17, 18, 19, 20. Down. Done. I don't think I will do more than this. So 520 means I've inflated it up to 5.2. Inflate. 14, 15, 16, 17, 18, 19, 20. Fluorosave down. So looks nice. I think it's good expansion now. Considering here also good MSA achieved. I think it's acceptable here also. Now we have entered the left vein. I think we've got some part into the aorta. Looks good. I think now we have good stop. So I think we've got a good result finally. Had some problems, but it was very difficult. This is the maximum level which we could achieve. We tried to dilate it as much as we could, and now finally these are the results which we have got. So we'll take final shoots and then we will be out. So it was a challenging case. We were not planning a ready diagonal bifurcation initially. We thought that we would just stent from LM to LAD and that is it. But unfortunately things had to take a turn and there were a few learning points during the case as well. This is the view and you can see that we have got a good result. Apical, again you can see that it's a very nice result which we have obtained. Show the other views. Circumflex is flowing well. There is no side branch compromise of any of the diagonals, septors, or this LCX. And yes, Caudal. So I should, in the end, I should thank at least the Medtronic team because it's very difficult to arrange all this stuff in Himachal. It's very difficult, especially with the floods going on and with the devastation it has caused on the roads and infrastructure. So I must thank Medtronic team actually who made this live case possible, and my team who have been brilliant actually in helping me throughout. So I think it's a very nice result. With this, I must thank everyone actually who was involved in successful completion of this case and should thank the patient also because he showed a lot of patience. Thank you so much.